Anyway, I'm going to present you in a more recent approach for pancreatic surgery with enhanced recovery after pancreatic duodenectomy. First of all, this is a picture in the center of Lyon. You know, we have the chance to have lots of star chefs and have good food also in Lyon. So my topic today, I will expose you what is ERAS. We will see the challenge in pancreatic surgery. We'll see if it works, causes of failure, and how to succeed the program of ERAS. First of all, ERAS. ERAS goes for enhanced recovery after surgery. Now we talk about the context of patient-centered care. So the patient is the center and everything is happening around. We have the first view that the patient is here and these are the medical staff. So we are with the nurses, the physician, the staff, the anesthetist, paramedical, the operating theater. We have research which may influence us as the evidence-based. So this is a situation which is quite reductive of what is really happening, because all this happens within an institution. So for treating the patient, you have to take into account what's happening around you in the institution with the administration, the hospital cost, the ICU, the income, the ward bed. Pharmaceutical industry will also interfere in our decision and the way we treat patients. And even at this stage, things could appear easy, but you have to take into account the national economy, the health costs, resources, investor communication, health service. So treating a patient now become more and more difficult because you have to take all these points in account in the decision making. So going from this, we see that several decades, it started in the 60s in USA, the fast track program, which was developed more in the 90s with the advent of laparoscopic surgery. And basically, fast track surgery was based on the will to reduce the health cost, which appear very interesting with minimally invasive procedure. You reduce the length of stay and you reduce the cost. So this was the fast track surgery, but you need to select the patient because you cannot apply it for everyone, and you have to accept high readmission rate, which is the case in the 90s. You do fast track, patients stay less long, but you have to select patient and you have high readmission rate. So finally, it is not good for the economy. And after the fast track program in Europe, a group of surgeons developed the program of enhanced recovery after surgery, and the aim was not to reduce the length of stay. The aim of the ERAS program is to reduce the perioperative stress, reduce the perioperative complication, and improve the outcome. And by doing this, you have collateral effect of reducing the length of stay without increase in the readmission rate, and finally you have less cost. So the patient get benefit from the program, and the hospital and the economy get, national economy get benefit from this approach. So we have to change our practice. We have to develop more and more teamwork, multidisciplinary approach in the patient interest and also for the national economy interest. So we have to improve the quality of what we are doing. The ERAS Society published in 2013 the guidelines for perioperative care of pancreatic duodenectomy. These are guidelines which mean that it's sort of timeline for procedure that you have to put in treating patients. You have items that you have to do preoperatively, other you have to do intraoperatively, and other postoperatively. You can also stratify them according to the item should be done by surgeon, by anesthetist, or by the paramedical staff. So to implement this item, we have to look at the challenges we have in pancreatic surgery. We usually have patients with undernutrition. Preoperative biliary drainage is still a problem. Patient stress, nasogastric tube, because we have many upper GI anastomosis. What about abdominal cavity drainage, early feeding with multiple anastomosis, and the high morbidity of the procedure? In fact, if we compare the pancreatic cancer and colorectal cancer, you see that pancreatic cancer is at higher risk of postoperative complications because the patients are older than in colorectal cancer, and they have more frequently undernutrition compared to colorectal cancer. So this is one of the things we have to improve before operating the patient. If we also look to the pre-operative biliary drainage, we have randomized control studies showing clearly that draining systematically patient before Whipple procedure do worse compared to the upfront surgery. And despite this study from the Netherlands, which now several years ago, we still see in France, in our center, almost half of the patients have biliary stenting without any indication, because it's only the procedure. The patient goes to see the gastroenterologist, he sends him for echo endoscopy, he has still limited jaundice, so they insert the stent, and then finally they send the patient for surgery. And sometimes they put the stent even before doing the CT scan or the MRI. So we have a lot of effort to do to improve this thing. We also know that patients with pancreatic cancer, they have a lot of stress. They know that they have cancer. They know also from internet that the outcome is very bad. And we add another stress by letting them fasting before the surgery. We know that the preoperative fasting is not good for patients. This is old dogma. We have to stop keeping patient fasting before going to the operating room. We have to give them preoperative carbohydrate load. And by fasting, we also increase the insulin resistance. And if we go back to the physiology we learned in the first medical school, year in medical school, we know that stomach will empty within 2 hours after liquid ingestion. So we don't need to keep the patient 6 or 12-hour fasting before surgery. There is no evidence by doing this that we have more complication, neither aspiration, pneumonitis. We have to decrease the insulin resistance in the post-operative period, and the patient is more comfortable when he had carbohydrate load. So now we change the practice. We give the patient carbohydrate load. It's even apple juice the day before surgery at midnight, and 2 hours before going to operating theater they get 400 milliliter, except for, of course, of diabetic and patient gastric empty syndrome. To reduce patient stress, we used to give pre-anesthetic medication, and this also is very, illogic and things that we have to stop. The best way to reduce the patient stress is a proper patient information. If you would give good information to the patient, if he knows what is going to happen in the theater and afterward, you see this patient is going for a combined pancreas and liver resection. He has no pre-medication, he's walking to the theater, and you look, he's happy because he has good information before surgery. So we stop doing pre-anesthetic medication for all our patients. We experience the patient walking to the operating theater for major surgery, Whipple procedure or hepatectomy or esophageal, and we see for first 57 patients in pancreatic surgery, almost all the patients were happy with the procedure. Waiting time was less than 10 minutes, and 95% were completely satisfied by walking to the theater. So we don't need to pre-medicate the patient. They can go walking to theater. So we have to change the practice. No systemic pre-anesthetic medication. Best pre-medication is patient information. We have to evaluate the anxiety scale of the patient, use short half-life drug, and rapid mobilization. At this patient, you see 82 years old patient, 2 hours after Whipple procedure, he is in his room, already in the chair outside the bed. And this is the way you mobilize the patient earlier, and you get better result. If we keep the patient in bed for 7 days before giving him food or mobilize him, is very bad for the outcome. Fluid balance. We also know that we have to keep a zero target balance. we used to have anesthetists that give fluid, and at the end of the operation,